Hello, everyone. Welcome to Healthier Here's August Partner Learning Webinar. Today, we're dedicating this session to learning about a new model for improving care for multi-visit patients, an introduction to the MVP method. Before I turn things over to our guest presenter today, I'd like to talk through some of the logistics about how you'll ask questions during today's webinar. Next slide. So this slide shows a screenshot of essentially what's your view as an attendee using GoToWebinar. You can use that orange arrow at the top to expand or collapse this pane. If you want to speak a question, the first thing you would do is click that hand button to raise your hand, and then I'll chat with you to see about unmuting your line. But the easiest way to ask questions tends to be just to type them in, and then I'll speak them out as they come in. So if you have a question, please go ahead and type it into the questions box, hit send. It comes directly to me. It does not go out to all participants. And then I will pipe in with your questions as we go along. So that's how to type in a question. Next slide. And as I had mentioned, that little hand symbol, if you'd like to speak your question, go ahead and click that, and I'll communicate with you before unmuting your line. But this is very important. If you would like to speak your question, and if you've dialed in by phone, make sure you've selected phone call, phone audio, and that you've entered your audio PIN. Because if you don't enter your audio PIN, I'm not going to be able to unmute your line so you can speak your question. Yeah, so that's why you raise your hand, and we do a little bit of communication first to make sure everything is in order. So those are the logistics for today's webinar, and thank you again for joining us during your lunch hour today. I'm going to kick things over to our guest presenter, Sue Bergman from WSHA.
Hi. Thank you all. Glad to be here today and share this initiative with you. Today we're going to be talking about improving care for multi-visit patients, or what we're abbreviated as MVP. And this is a newer term that we're using for high utilizer or frequent flyer patients. So we'll be doing an introduction to the MVP method today. Some of you may have heard about this or seen previous webinars and different versions, and I hope that if you have heard about this before, that this is still a really nice overview. And we are really excited to also have the Harborview Medical Center MVP team to also share their specific experience implementing MVP today. First off, I'll introduce myself. I'm Sue Bergman. I'm Senior Director of Safety and Quality with the Washington State Hospital Association, and I lead WSHA's work on reducing readmissions as well as health equity. So as I mentioned today, the objectives are to do a high-level overview of the MVP method and some of the implementation steps to start doing this work at your facility. And then we'll have the Harborview Medical Center team share their specific experience in their pilot and then share their learnings and barriers that they've identified through this process. So first, I'd like to start off with WholePerson transitional care, which is a strategy or a method introduced by AHRQ called the Aspire Guide, and it is a patient-centered approach to addressing the medical, social, and behavioral needs of patients. And I've cited the source here at the bottom with a link that you can access the guide right from this PowerPoint here. And I encourage you, if you're not familiar with Aspire, that it is a really great foundational work for approaching this, the medical, behavioral, and social factors that really many of our patients deal with. Next slide. I want to highlight that Dr. Amy Boutwell, she's the president of Collaborative Health Strategies. She's a practicing hospitalist in the Boston area. She's the developer of the Aspire Guide that we just mentioned, as well as the MVP method. And Dr. Boutwell coined this term MVP method. But in the Aspire Guide, at the very last section of the Aspire Guide, it's called providing specialized services to high utilizer patients. That is essentially the MVP method. Dr. Boutwell just coined this term MVP after publishing Aspire. So this is really, again, MVP method is that next step or specialized services for this really specific patient population, but it's still the foundational services that are outlined in the Aspire Guide. We had 6 hospitals in Washington State that had the opportunity to receive direct coaching from Dr. Boutwell. The 6 hospitals are listed here, and then as I mentioned, we have Harborview here today to share their experience. And so our goal is that we learn from Dr. Boutwell, the foundational work from Dr. Boutwell, and have now 6 hospitals in Washington, 1 in Alaska as well, that had the opportunity to start this work, and now it's our goal to continue spreading this across our region. So with that, I'll start off with what a multi-visit patient is, how we define it. And it's a patient with 4 or more inpatient admissions within 12 months. And it is really strictly defined in utilization, so not by their diagnosis and their utilization, that it is 4 or more inpatient admissions in 12 months is really the way to define it, and not further stratify it. Not that you're restricted from doing that, that's just really the guide, is that it is a very small percentage of patients, and so by further stratifying it by diagnosis does limit you to be able to reach this really vulnerable population. So as we mentioned, it is defined by high utilization, but these patients often have comorbid conditions and complex medical conditions, so that when they do present to the emergency department, they're almost always admitted to the hospital. And lastly, I'll mention that we do define the utilization by inpatient admissions. That's full inpatient admissions, not OBS or ED visits, although these patients might also have multiple OBS and ED visits, but we define it by that inpatient admission. So we're able to pull data for Washington State to see what MVPs look like in our state. And this is the data source here is the Washington State CHARS database, which is the inpatient hospital claims database for our state. And the distribution, or what MVPs look like in Washington State, is that they make up 7% of all hospitalized patients. So that's unique patients that are hospitalized in Washington State, meet this MVP criteria with the definition that we just shared. And they contribute to 20% of all inpatient admissions. So that's just out of all admissions, 20% of them come from MVP. So you can see there's a disproportionate amount of unique patients to that higher distribution of actual admissions. And then they contribute to 55% of all 30-day hospital readmissions. And that's all cause, all payer readmissions. So what to highlight here is that it's a really small percentage of patients, 7%, contribute to more than 50% of our 30-day readmissions, even though this definition is not defined at all by a patient coming back in 30 days. And this distribution, through Dr. Boutwell, we've learned looks very similar, almost identical across the nation in every state. And in every hospital in Washington State, small and large, urban and rural, this distribution is very similar. So it really doesn't matter what size you are, that it's still a very small percentage of patients contributing to more than 50% of 30-day readmissions. And so for that reason, this is one of WISH's major readmission strategies. And so this slide outlines really what the contributing factors are to make a patient or that can contribute to somebody having that higher utilization. And most multi-visit patients have co-occurring medical, behavioral, and or social needs. And so this is just a high-level overview of what those kind of buckets might look like. This list is certainly not exhaustive, but we are really quite familiar with what a lot of our medical conditions that bring our patients to the hospital. But the behavioral and social factors really that are outlined here, these are often unaddressed or unmet needs of our patients that are not easily identified by the way that our health system currently works. So as I mentioned, MVPs, they have unmet needs, and that those unmet needs are what drive them to the hospital more than any other patients, and that the utilization is a symptom of that unmet need. And that's what we call the driver of utilization. So what's bringing this patient to come to the hospital so many times, and the driver of utilization is the person-centered root cause of their utilization. And this is something that needs to come from the patient. It's not their admitting diagnosis, and it's not their chief complaint. And oftentimes it is not in their problem list at all. So one way to kind of look at this and reframe this and think about it is that we see lots of patients that get hospitalized with multiple comorbid conditions, but not all of them are MVPs. In fact, only 7% of them are MVPs. So if we were to take this example here, that there's two patients, Mr. Smith and Mr. Johnson, that have very similar, or in this case identical, but in this theoretical case it's identical, but have multiple comorbid conditions that we see a lot of our patients have. But why is Mr. Smith an MVP and Mr. Johnson is not? What differentiates Mr. Smith from Mr. Johnson? Next slide. And so if we were to take a deeper dive and look at Mr. Smith, 42-year-old male with this list of comorbid conditions, and as we've identified that he has more than at least four or more admits a year, when he presents to the emergency department with chest pain, shortness of breath, nausea, weakness, any of those things, presents to the emergency department, he's going to get admitted to the hospital at least for a rule out nearly every single time. And while he's in the hospital staff is going to be working on his, let's say, heart condition as a rule out, talking to him about how to manage his cardiac or comorbid conditions, and we'll discharge him after a couple of days when the rule out is negative. But what really we want to focus in here in this example is that what's driving Mr. Smith to come to the hospital, although he might be complaining of chest pain, he may be thinking about his housing instability. Does he have a safe place to sleep tonight? Does he have money to pay for his medications as well as his food? And so the example here is that Mr. Smith is coming to the hospital for food, shelter, safety, security, and that is what is actually driving him to come to the hospital. He knows if he complains of chest pain, this may be obvious to him or not obvious to him, but when he presents to the emergency department, he knows that there's going to have food, shelter, safety, and security for the next few days. So I just want to go over at a high level, what are the implementation steps of implementing whole person transitional care specifically for the MVP population. So the first step is to identify that you have an MVP in your hospital. And that sounds like it's a really easy thing to do, but it's really actually not. Most of our electronic health records don't have an easy way that you can set up a flag or a report for a specific population. So we cannot provide services to these different services to these MVP patients until we can reliably identify them as they're admitted to the hospital. And so that does take some work with technology at your facility, but there are ways that you can get started in identifying your MVPs in a little more manual process until you can get that electronic process set up. Just at a high level overview, that you can pull a roster from your EHR where you can identify patients that were admitted to your hospital with at least 3 inpatient admissions in the last 12 months, and then cross-reference that with a daily admit list to see if any MVP has shown up at your hospital then. So manual step, not the way you would want to do it long term, but I don't want you to wait 6 months to get started to wait on something that you would have to set up in your EHR. Harborview is going to share shortly how they did it within their system to give you an example of a way to do this reliably. But the ultimate goal is you want to set up something in your EMR so that it is automatic and everybody can know that this is special patient that needs specialized services. And the reason we want to reliably identify them in real time is so that we can assess them at the bedside while they're in the hospital. And we use the word assessment. Dr. Boutwell really started this off with it as an interview, but it's much more than just a dialogue. The assessment, what the patient's telling you and how they're behaving tells you a lot about some of the drivers that might bring them to the hospital. It's important that this is not a chart review, that this is a conversation specifically led by the patient, not necessarily by the healthcare person doing the assessment. So techniques like motivational interviewing are a really important skill in this part of it. But even if you're not trained in motivational interviewing, you can get started on this right away. And the purpose is that we want to identify what that driver of utilization is. So it's not in their chart. The chart's going to talk about all of their medical conditions, maybe some of their social or behavioral conditions, but not as the main focus. And so it's really letting the patient tell you what it is that is bringing them to the hospital. And so then the next step is to develop a plan. We want to develop a plan that addresses their unmet need to slow down that cycle of utilization. And this plan should be co-developed with the patient and or their caregivers. And it should be something that's feasible and gives them clear guidance. This isn't stop smoking tomorrow, stop drinking forever. This is, what are the steps that you can achieve, small achievable steps that you can achieve so that you can have your needs met outside of the hospital. And then we want to link the patient to resources in the community where they can have their needs met in the community setting and not need to come to the hospital for those. So that could be in outpatient clinics or primary care for some circumstances, and others is connecting them to community resources to meet their more social needs. This linkage is a warm handoff. It's if at all possible, an in-person meeting with the patient while they're in the hospital so that they have that understanding of a human that's going to help support them. And this is absolutely not a paper referral. These patients need somebody to really help them navigate the system and to get their needs met. And then finally, we need to plan for their return. These patients have have learned that they can come to the hospital to have their basic physiological needs met, and that's going to take some time to slow down their return. So we want to prepare the emergency department for when they come back in. Now, if the patient returns with a medical necessity, needs to be admitted because they are truly sick, we will still admit them to the hospital. But if they're returning with their stable chronic medical conditions and they're really coming back to have their unmet needs met, then we want to arm the emergency department with information that tells them about the driver of utilization, what that plan is, and how to connect them back to the community to have their needs met. And we have a system in place in our emergency departments through EDDI where we can easily share that care plan and that infrastructure. So before I turn it over to Harborview, I just want to reiterate that this is going to take several attempts often to engage your MVPs, especially those at the higher end of utilization. So your patients that have 4 to 6 visits per year versus somebody who has 10 plus, it's going to take varying degrees of support to slow that cycle. And then I just want to say that I really want us to help reshift the way that we think. So if we identify a patient that's refusing services, this is an opportunity to try something different to engage them. So with that, I just want to pause if there was any questions at this point.
I have no questions so far.
Great. Well, I want to really excited to have the Harborview team here share their experience with a pilot project of implementing MVP. And we have 3 team members. If you could go to the next slide. 3 team members. We have Mona Chambers, who is a project operations specialist in inpatient care management. We have Kari Nasby from Social Work Supervisor in Ambulatory Care, and Ellen Robinson, Clinical Analyst in Quality Improvement. And I will turn it over to them now to share their experiences.
Great, thank you, and good afternoon. This is Ellen Robinson speaking. We're excited to share with you some information about our 6-month pilot project that we worked on with Dr. Boutwell on this MVP project. So as part of the Aspire work group or work that Sue alluded to earlier, we needed to do some baseline analysis to have an understanding of who these patients were. So as she mentioned, we defined MVP as having more than 4 visits in a 12-month period. And for us, we had about 240 patients in that cohort. They made up more than 1,300 inpatient encounters. And you can see the breakdown here by race. And we also wanted to highlight what were some of the other conditions that we thought might be having an impact on their utilization. So you can see we have about 47% of those patients had a mental health condition, 40% had about some form of housing insecurity, more than 50% had a substance use disorder, and of those patients, 25% actually had all 3 of those conditions. The majority of our patients were male, and they were on an average about 56 years old. What was interesting is we found that almost 15% of the patients were non-English speaking, which really helped us when we were forming our team to be ensure that we called in and got help from our cultural care mediators team. And then you can see the breakdown by payer, and also the majority of these patients are discharged to, quote, home. As we know, there's not necessarily a specific a diagnosis disposition for homelessness or shelter or respite. But once, most of these patients are not going to be placed, which is why they're probably having such high utilization. So we can go to the next slide. So as Sue mentioned, what we essentially did was just run a real-time kind of web-based report that our team could access through the internet that just did a count of everybody that was in a patient bed today. And we could either look at it by people who were admitted on a certain date. So, hey, it's Monday, I'm going to go in and run the list to see everybody that got admitted yesterday that has had at least 4 admits. Or you could run it to say, here's the whole population that's in-house right now, that's an MVP. And then we pulled in some details that we thought were important around language, again, as part of our cultural mediator group. Some of the insurance information we pulled in because a lot of our patients are actually on a managed Medicaid plan and they may have a caseworker, so we wanted to be sure we could look at that. We did a count of their previous admissions, and then the far column is just their previous housing status if it was noted as being elsewhere for home. Okay, you can go to the next slide. So one of the things from the MVP learnings that we took away was there's a suggestion that you could actually look through this list as a non-clinical person. So Dr. Boutwell mentions the concept of this air traffic controller that could do a quick look at the patients and then determine, who needed an interview, who needs to have some different clinical interventions. And so I just did that as a test, and this was just one day earlier this year where we had 25 MVPs in-house. That was a pretty large load. And just to show you some breakdown of how we've been kind of framing some of this work is, more than half of those patients were not on their 4th visit. They actually had more than 4 visits. 9 of the patients were just getting to that 4th visit. Again, 7 of them were non-English speaking. We had 4 with housing insecurity, and then again, the breakdown. But typically for our volumes, there were about 3 to 5 new patients per day. And we found as far as trying to start triaging the patients, it may take anywhere from 5 to 15 minutes a patient. And then there's always that afterwards tracking cases if we have made some sort of a link. So that was kind of our baseline analysis and identify. And now we'll move on to Mona's going to speak a little bit about her assessments of the driver of utilization.
Hi, this is Mona. Once we've identified the patients, then we would move on to the interview of the patients, and that's a really crucial piece to finding out what the driver of utilization is. So we kind of created using Dr. Boutwell's template and kind of her idea and infrastructure, we came up with this kind of structure for having different people go do interviews. So we would start with the medical one-liner, kind of finding out from the patient, from the notes, what the reason was for the admission, and then looking at their history of, how often they came to the ED, how often they've been seen in the clinic. So really looking at those other tools, resources that the patient maybe had touched throughout the last few months. The unique thing I think about MVP is that it looks at not just their use of the ED, but really how often they've been admitted. So counting those inpatient stays helps you to look at the patient a little differently. And then for the driver utilization, the interviewer, we use a lot of motivational interviewing and really kind of asking the patient why they think they're returning so often. And you'll get a variety of reasons from them, typically not related to their clinical diagnosis. So patient, one example is she felt she was getting readmitted frequently because she was getting discharged to the street with her cellulitis and not being able to put her feet up because she can't stay in the shelter during the day. So that's what she thought was the reason for readmission. So just one example, one patient kind of lost an engagement with her team, lost her phone, and just didn't know how to figure out how to connect again. And that was often the case with a lot of our patients, that they had difficult time navigating really the system that we have. So the interview takes a little bit of time to really allow the patient, engaging the patient to tell us what they felt were the reasons for admission.
Great. All right, so next slide. After we did a few weeks of interviews, we realized that we needed to probably get together to discuss some of these cases, to be able to share information across the system. Everybody has their own lens from which they look at the system, and so this really allowed us to share information. So I'm going to let the team speak a little bit about our weekly team huddles that we had.
So this is Kari. So one of the things that I think was useful was to not just have a multidisciplinary team, but also have a team that was across all areas of care for Harborview. So we had folks from the clinics, we had folks from the with an ED perspective, and people from the inpatient perspective, and that and people who really span all of those. We have a group of interpreters and cultural mediators who work in all of those areas, and so that having that group of people come together for Huddle really helped us to come up with a fuller picture of the patient experience and what might be useful for interventions or linkages.
I think it also helped us to know what services were available in various settings. I remember there was one meeting where we were talking about, this person didn't follow up in cardiology clinic because he follows up in this clinic. Oh, well, do we know they can do echoes in that clinic? Oh, no, we didn't know that. They could do echoes on Tuesdays. We have someone that, okay, they don't have to go to this clinic because that service is available over here. And that was just, a gap that just not everyone's going to know unless you work in that clinic.
We also had one nurse or physician that came from our outpatient clinic that was specific to serving the homeless population down in Pioneer Square. And so they had a lot of resources that the inpatient team and some of the clinics maybe here at Harborview weren't as familiar with. So really getting that knowledge from other team members of what they can provide was very helpful, at least in our system. And partially that's because our system has a different EHR for inpatient, different EHR from outpatient. So each team member actually talked about where they look at to see what information to dig for the patient. So where to find case managers and where to find their prior housing, where to find who the patient has talked to before. And so we kind of, as a group, realized that we were all looking at the patient differently and not getting a larger picture. And the MVP digging into these patients more intensively helped us to understand what they were seeing as a patient that we might not be looking as well. So.
Great. And on to the next slide. So I think that what we took away after these huddles, we really just brainstormed that we realized we do have quite a few actually services already in place, and it's just a matter of ensuring that the patient gets linked up with those services. I remember Dr. Boutwell quoted at one point, there's no such thing as a referral for an MVP. You can tell somebody to go someplace time after time, but if they don't go, the referral is not being completed. So this was just a brainstorm list, and again, I'll let the team kind of comment on some of these learnings.
Yeah, just to tag on that referral, this is Mona. So oftentimes we'll send a referral to a clinic, at least speaking from my inpatient background, we send a referral to the clinic and assume that, it's been done, it's going to take care of, they're going to get an appointment. But then come to find out it didn't happen because, one, they couldn't get a hold of the patient, or two, they needed a piece of paper that needed a signature. So there's just a variety of reasons why a referral doesn't get completed as an actual clinic appointment for the patient. And when you're a nurse on the inpatient, you don't necessarily think about that until you talk to your counterpart in the outpatient and they explain their process.
I think as a social worker from the clinic perspective, this is, a lot of what social workers do is try to reduce barriers to care for patients in the clinics and with these transitions. And so, this was a project that really emphasized how necessary that is and the function that serves. And I think, again, just how complicated our systems are for patients to navigate, which is something that Mona pointed out earlier, but is really true. So one of the things we learned.
Great, next slide. So what we've come to at this point, again, still kind of in development and pilot project, is these were really kind of 5 high areas that we think we're going to work through as kind of having this driver of utilization response system. So from what we learned from our root causes, we realized that primary care engagement is critical. We may think the patient has a primary care provider, but when we speak to them, they haven't seen them in 2 years. They don't like that place. They can't get in. They want someone new. So that's been something that the inpatient team's been trying to do a little more detailed assessment on. We know chronic symptom management is an issue. We're working hard with our heart failure, COPD, renal, and diabetes teams in terms of creating a whole patient kind of care plan. As Mona's already mentioned, inadequate housing is an issue, as people know, all across the Seattle area. We've mentioned the cultural case managers, and then again, trying to link patients with SUD treatment services while they're inpatient so that we can help transition them through the community, into the community for those types of services.
So for the next slide, and as already kind of touched on before, there's a lot of communication challenges. I don't think is unique to Harborview, essentially. I don't see a show of hands, but maybe yeah. Anyway, so we kind of discovered that, and I think that our hope is that once we come to a single EHR, that this will eliminate a lot of these challenges for us. But knowing that and how that affects our MVP population helps us to give them additional tools and maybe more hand-holding to help them navigate through those communication challenges that we ourselves face.
Yeah, and I'll speak a little bit to the warm handoffs. So, again, the point that referrals are not as effective with this patient population, and that efforts to do warm handoffs, to look at what hasn't worked in the past and to try to change it up so that the positive connection happens this time. That's the goal, and it's hard because it is time intensive. And so I think one of the big things that we learned is that this kind of care coordination, these warm handoffs, these are time intensive interventions.
And I think the last point is that I think a lot of people on the call are familiar with the EDIE system and the care plans. And, what we've struggled with there is that those care plans aren't always complete, or the information isn't as thorough as we might like. And for us anyway, it's not really integrated into all of our ED providers' workflow. So while there may be something in EDIE, it would take the provider having to go take a look at it, make sure it's up to date, before they can kind of make an actual plan that might prevent an inpatient admission.
Yeah, and then this is Mona. Just to kind of talk about the warm handoff a little bit more. Once we see our patients on the MVP list, and we know that they've been touched with by our COPD case manager, then we would actually call our COPD case manager, and he will go visit the patient, actually do the interview that I spoke of a little bit earlier, and then before the patient discharges. And so he's made that connection with that patient, and his role allows him to actually follow the patient once they discharge. So he continues the relationship with the patient from inpatient, and then as they move on to the outpatient, kind of, again, help them navigate that system. And I think, Kari, you were doing the Healthier Here, kind of connecting them to a PCP in our aftercare clinic as well. So helping that piece. So I think that warm handoff is really a lot of our focus during our MVP pilot.
Right. And I think the last phase of MVP that Sue alluded to is this plan for the return piece. And I think that's really where we are at this point, whereas, so, we know who's here, we know who's coming back, but, how do we plan for that and re-engage them each time over and over in a consistent way? And I think that's really where we're kind of struggling at this point. So next slide. So one thing we have been doing is just tracking. At this point, we haven't really made any improvements on our overall utilization, but just so people can see a way that you can frame the issue to potentially other stakeholders in your organization. So essentially what we do is for the month, we count up how many people were discharged that were also an MVP. So you can see the month of May, we had 62 patients that were in the hospital in May that were on that MVP list. And then how many of them readmitted for any reason in 30 days? You can see about half almost. And then we do a count of their patient days. Again, as a lot of hospitals are struggling with census issues and patients potentially who could, and avoidable patient days, we just thought that this helped to frame the problem of MVP to help continue to gain more support for the program as we move forward. Next slide. And so this was just, I wanted to throw in for people as a resource. The advisory board did a great webinar a few months ago called Care Management 101, where they really talked through if you were kind of starting a new care management program, what would you do? And one of the quotes I took away from this was, more FTEs is not the answer, but really what you want to do is decrease the gaps and duplication across the system resources that you already have. And they just mentioned these kind of 5 attributes of effective care management organizations. And I think we're still really in the early phases of care management here and kind of working through, we know we have pockets of best practices, but how do we standardize that across our entire system? That's kind of where we're at. Next slide.
Yeah, and so on this next slide, so Harborview, maybe about a couple years ago, we've really done a big adjustment to our care management teams. So there's been a change in roles and identifying where our staff can be most effective and reviewing kind of what resources are best to support them and to help the patients kind of move through the system. And so there's a lot of change going on and improvement in process and workflow, and MVP can actually is one of the things that we looked at to really integrate into the workflow of our care management team. Still work to do on that, and I think one of our barriers is really our EHR, because MVP is really about connecting inpatient to outpatient, and without an EHR that unites those two, we can't move forward too well on that. So when our EHR is one, we're hoping that MVP can be vital in kind of alerting the whole team, not just the inpatient team and not just the outpatient team, that a patient has come to our system and needs extra attention. So
Right. And I think one other future hope, and I think as part of the Healthier Here project, we hope to see more of this, is just, these team huddles were very, very useful and effective. And how do we also expand that to include other community partners where some of these MVPs may be receiving services to help engage in this work? Next slide. Great. So we just wanted to say thanks to our team. Again, there have been a lot of people helping us on this pilot, and just to kind of lay out for others who might be important as you're forming a team yourself. And I think we're kind of towards the end of our information.
Thank you guys so much for sharing. Just want to check if there was any questions at this point.
Yeah, still no questions.
So there's a few things as you guys were going through that I just love to highlight, either things that I didn't mention or just that we saw in the other hospitals that were similarities that you guys experienced. So one of the things I wanted to call out was about what MVPs look like in Washington State from that CHARS database that we have. And I think you guys mentioned this, but that the average age of the MVP population is around 40 to 50 years old, and it's not all our older population. I just thought that was interesting. And that the distribution of visits for MVP patients, it's actually, when looking at it as the whole state, it's about 80% of MVPs have 4 to 6 visits. Like all, really the main volume is in that lower end, and that there's a patient, and then there's one patient with 35 visits in 1 year. But when you think about your high utilizer population, what you'll come to mind is the patients that are probably 10 plus visits a year, and that you really don't know that 4 to 5 to 6 visits a year unless those visits all happen really quickly and tightly together. But just something to think about from a data perspective. I wanted to highlight what Harborview said in that this work can really feel overwhelming or feel like it's a really big thing to do. And I like how you guys highlighted that you identified like the top 5 drivers of utilization and figured out what those pathways look like. And the important thing is just to start somewhere. Even if you help just one patient, it will significantly impact them in their life ongoing. So you don't even have to pick the top 5. You can pick the top 2 or top 1 and start there. But what a lot of our facilities that have started this work, social isolation is a really common factor that can be quite easy to help somebody with that, linking them to something in their community. That social isolation might be linked to something behavioral that might take a little longer to provide that support, but if it is just linking them to somebody in their community that can go check on them every day or frequently, not everything requires, like something comprehensive like finding somebody who's homeless a home. And then I just wanted to also just mention that Harborview's experience of this being tough work and challenging is everybody's experience. So I don't want to sugarcoat this, that this is easy work. But the way that I frame this is that as you start doing those interviews and assessments, it really opens your eyes to realize that we're not providing the correct services to the people seeking help in our hospitals for this patient population. And even just getting to the step of starting to identify what those drivers of utilization are, and just even if you don't do any of the steps after that, so you start being able to identify those patients in real time and understanding what the driver of utilization, the common ones in your patient population, and giving you some time to think through that and develop those linkages over time. It's just like doing the interviews that is part of the Aspire guide that I mentioned, just gathering that qualitative data to understand what your patients are experiencing. You can then, over time, develop the response that would be better to help those patients. So I'll just stop there and see if Harborview team, if you had anything else that you wanted to to share in response to what I said?
No, I think that's a great comment. I do agree that, potentially working towards those patients who are more on the early end of the MVP spectrum, 4 to 6 visits, and helping kind of slow the cycle at that phase might be more fruitful and more meaningful than trying to work on someone who's had 35 visits in 1 year, because there just may be a lot of other issues that may not be able to be addressed. So early identification.
And then hopefully those at 4 to 6 visits, if we're able to slow that utilization, they don't end up being 10 plus visits in the future.
Right, and I appreciate what you said about helping one patient can really make a big difference. I will always remember the first few patients I interviewed. There was one gal who she kept coming back. I think she was in that low range, 4 or 5 visits. I went and talked to her, and she said, yeah, I live in the streets. I just come because, I can't breathe. That she had COPD. And then I engaged her with our high utilizer group who works out of the ED, and they usually have resources for like housing and things like that. And she had met their criteria. So our high utilizer group met with her, found out, and they actually knew her, had been looking for her. They had not been in contact with her because they couldn't find her, and she had lost her phone. So they provided her with a phone, and as far as I know, I think they were able to resume that search for housing, and she had gotten her housing. And so this is just one example of a patient that this program made a difference on, because we were actually able to identify her early and know that she had some of these resources available and just lost connection with the people that were trying to help her.
Yeah, I think that's a great point of something that you already kind of touched on, is that there are a lot of resources available even within your system, that just connecting the dots and understanding all the services that are available and making it so that our patients can have access to them. It's interesting that the ED high utilizer group is looking for her, and you guys are trying to find a place for her. So oftentimes we have multiple groups trying to do the same thing, and it's just really finding, as Ellen mentioned, it's not necessarily adding more FTEs, it's allocating the resources that you have in the appropriate way for the right patient at the right time, to have the best outcome.
Great, and a few questions have come in, so I'm going to read these out. Our first question is from Rachel Freed from Connect, Virginia, so she's out of state. And her question is that in Virginia, she feels that they're still young compared to some of the work Washington State has done. So she's interested in some insights into how Harborview determined how many interviews were possible per day, given employee resources. She says that Virginia hospitals are having a hard time deciding how many MVPs or high utilizer patients they can realistically serve. Yeah, so I'd like to direct that question to our Harborview team.
So this is Mona. For the interviews, we were finding that we were having about at least 2 new admissions a day. Sometimes up to 5 is about the highest that I saw it. And the interviews take about 20, 30 minutes. And our goal was really to try and see the patients within 24 hours, maybe 48 of admission, just to catch that time period when the patient is actually ready to engage with us. As they stay here longer, it's a little bit harder to engage because they're ready to leave, or the teams are talking to them about discharging them. But when you see them early enough, they're really wanting to tell you, okay, these are the reasons why I'm here. So about 2 to 5 a day. My FTE was not dedicated to MVP, so I had to wear different hats. So I think it would be great if there was a FTE dedicated to MVP, because they can continue to follow and engage the patient, kind of like a care management model, identifying these MVP patients. And if you have like 20 a day that are in-house, an FTE focused on that could potentially help to really engage the patients and follow them and put them in the next level of care that might be more helpful for the patient. I don't know if that answers your question, but yeah.
And this is Ellen. I think one thing we thought at the beginning is, well, Mona will do some interviews, we'll get a sense of how this is going to work, and then we'll just spread it and have all these different people doing these interviews. And what we realized pretty quickly is that it's the same people going back over and over. And if Mona had some engagement with them and a little bit of a connection with them, it made a lot more sense for her to say, hey, I see you're back. And remember we talked about this last time, versus someone cold coming in who has no connection. So again, this was a pilot, but I think if we move forward with trying to make this more operational, it really feels like it should be the same person doing the interviews as much as possible to be able to continue with that continuity.
Great. Thank you so much for fielding that question. Before I move on to the next, I want to see if Sue had anything to add.
Yeah, I'll just add that from Dr. Boutwell's experience, on average, it's 1 to 3 patients a day that are MVPs in your hospital. So that's on average. 10 can show up in one day and none for 3 days. That 1 to 3 average for bigger hospitals is 1 to 3 new patients a day, and for smaller hospitals or medium-sized hospitals, that's 1 to 3 patients in-house on average. And Dr. Boutwell's advice would be like, if you can get one interview assessment done a day, that's fantastic, and then set a goal to try to increase that to 2 patients a day in a week or 2, and just kind of scale it up. But don't worry about nights and weekends when you start this work, or if somebody has shifts, that's only 2 or 3 shifts a week, and that's the person who's going to do it. Don't worry about the other days. Just start getting started.
Great. Thank you so much. I'll move on to our next and final question. This one's from Martha at Project Access Northwest. She'd like to know more about how this MVP work connects to the work being done by the MCOs, insurance companies, such as the Health Homes Project. So Sue, I'll let you take that first.
Again, we want it to connect to work that's already being done. So if an MVP is in the Health Homes program, we would want to connect them to the case manager or workers in that program. Same thing with, I think Ellen touched on that Harborview is able to identify if any of their MVPs are in the Medicaid MCO, and that they link them to their complex case manager. And so I think it's important to also just think about what is the specific driver of utilization, and developing a link that addresses that unmet need. Linking them back to existing case management programs that they have might very well accomplish that need, and it also might not if it's very socially driven. And so to really think that it's not always just think about case management, also think about what that specific driver of utilization is, and to ensure that the linkage that you're referring them to has the capacity or ability to help them with that need.
Great, thank you. And those are all the questions that have come in.
I can just go to my one last slide where we just want to, you can click. I didn't realize I had it. Oh, I didn't realize I had it. Okay, so so we have so the opportunity that be on today for training on MVP. Since this is being offered with Healthier Here, this is something that we're offering to the to providers and healthcare providers in the King County area. So I'm going to highlight what this is available for King County. If you're in Washington and not in King County and interested in MVP, I encourage you to still reach out to me, because we can offer services to you outside of this. So if you're in King County and interested in working on MVP, our goal is to have later this year. We don't have a date set yet, and so that's kind of loose. We're figuring those logistics out. But we'd like to offer an in-person boot camp for hospitals that are working on MVP, like specifically to work on implementation at their facility. We target this specific event really around the hospital so that the hospitals can get started on this work. And then following that, early next year, we'd like to have an in-person boot camp where we would bring hospitals and community providers to really focus the day specifically on what Harborview kind of highlighted is the tough piece, is that linkage. And so bringing together the community and hospitals together to really intensively work on what that would look like. And then additionally, WISHA is here to provide monthly coaching calls or whatever cadence would be appropriate for your facility, for our hospitals working on MVP implementation to help you through this process. And yeah. So that's what we have available to offer those in King County. And I think actually on the next slide is my email. It's also in the beginning. Yeah, so please don't hesitate to reach out to me. If you're interested in this opportunity here with King County, please email me. If you're outside of King County still, please email me. I would love to talk to you, figure out what would work for you to help spread this to everywhere in Washington State.
Fantastic. Thank you so much to everyone for participating, and a big thank you to our presenters, Sue, Ellen, Mona, and Carrie. And as a follow-up, I'll be sending out a PDF of these slides. I will include Sue's contact information, so you can contact her about these MVP boot camps if it's of interest to you. We'll also be sharing a link to the recording of the webinar in case you have any colleagues that you would like to forward that to if they weren't able to participate with us live today. So that's coming soon. I also want to mention that when you log off from today's webinar, you're going to get a follow-up survey. One of the questions is, do you have any ideas for topics for future partner learning webinars? We are in search of topics to bring to you in 2020. So if there's anything of interest, please share it with us, and Healthier Here will get right on that. So thank you again for participating today. We'll see you soon.